So have a break, have a Kit Kat, right? So these are kind of our nightmares, right? They're doing well until they're not doing well, and then they're really not doing well. So this is a case of mine that I'll go back to towards the end of this. 73-year-old, as crazy as these ladies here when she came in. I did a reverse on her, and she looked pretty good. Lost a follow-up. These are last follow-up that I saw her, and then she comes back at the end of this presentation. So these can be obviously devastating complications, and the incidence varies. Obviously, as you get older, the propensity for this can be higher, and also with high energy mechanisms. Intraoperative, if you look at kind of the risk factors, aggressive reaming, you know, I always say to the fellows, undersize or revise. You don't need, you know, to line fit your humeral stem. Underestimating soft tissue contractures. And then perioperatively, understanding your patient. Do they have any sort of neurodegenerative disorder, Parkinson's, bad osteoporosis? Is this a revision arthroplasty case and you underestimated the proximal porous coating of the stem, female gender? And so we're willing to take that risk. Because a lot of times what we say, we're going into the case, and then we come out and we say, I wish I hadn't taken that risk. Classifications for me are kind of like, okay, keep it simple. High, low, and sort of what do I need to do, right? So there's a lot of different classifications out there, but essentially if he looks at you and you go, crap, that's probably one you have to fix. If you look at it and you go, let's wait it out. So what to do? I don't know what to do. Ask your friends, help them talk you into something that maybe makes more sense to you, maybe. You want to fix it, let's see, or you can kind of squint and be Mark and say it'll be fine, I don't see it. So conservative treatment, and a lot of these conservative treatment can work. And so immobilization, don't underestimate the power of immobilization, especially if it's a long oblique fracture pattern, spiral type A or B fracture, if it's minimally displaced fracture distal to the prosthesis. And also, you know, assessing if your prosthesis is stable in the proximal bone. And also, obviously, there is a patient attached to the arm. And I know we always remember that, but you got to think about that and the perioperative social needs that it'll require if they have surgery or don't have surgery. So, you know, non-operative management does have a role, and probably a predominant role in the majority of these for me. And it's been shown in multiple studies. Some of these are a little bit dated, but again, for certain types of fractures, it does take a while for them to heal, but they can heal and heal pretty well with conservative management. And how about when surgical treatment is necessary? So, you know, operating on the right patient is key. And so displaced intraoperative fractures, displaced postoperative fractures, patients that have failed conservative treatment, and unstable stems. Otherwise, if you pick the wrong patient, you're going to end up like that guy, down in the corner, out cold, just regretting your decision immediately. Surgical treatment, this is where you have to be creative and know all your options. This is where you sort of have to incorporate a lot of what Jack and Mark were saying about being patient, thinking about, do I need to convert to a long stem? Do I need to do some sort of combination RAF with strutting, et cetera, and supplemental fixation? And again, I think the outcomes can be reasonable here, but these are not typically often home runs. So these are, again, in the literature, you can see that with various constructs, whether it be cerclage wire for proximal fractures and cortical struts, as well as revision arthroplasty with long stems for more complicated fractures. So periprosthetic humeral fractures are devastating complications. Fracture management is highly dependent on the fracture characteristics, fracture setting, patient characteristics, surgeon preference. Stick to the indications, and sometimes you do need to leave it alone. And the available options out there do show good outcomes, but again, make sure the patient understands they're not going to go back probably to their pre-injury or pre-morbid level of function. So back to my case. So again, she's looking pretty good. She disappears, which is perfect. She comes back 3 years later, sustained a fall while walking with her walker, admitted to the hospital. She has this. So you look at this fracture pattern and you say to yourself, well, it is displaced, it's kind of at the tip. Stem, I thought was pretty stable, but I was prepared to take it out if I decided to operate and revise her. So intraoperatively, fluoro, you have kind of the whole set of things available. decided to proceed with RAF with plate and strut fixation, and was able to retain the stem, had good fixation of the stem, so did not have to yank the stem to either a longer stem pattern. So this is a patient that did well. And follow-up, you can see she got some HO, but overall recovery of function was pretty good, and she's gone again until the next time. Case number 2, this is a true story. This one really sucks. So 76-year-old male, right-handed with Parkinson's. I did his left side in 2022. He did fantastic. And there's his left side, rates himself about 80%, and then comes in, his right shoulder's bothering him a lot. Well, successful once, be successful again. So rates his shoulder about 25%, pains at about 10 out of 10 at times, limited function. This is shoulder, obviously a fairly significant amount of bony deformity on the glenoid side, medialized, and did a reverse. I thought it went well, and then 5 days later, I get a random text. I give everyone my cell phone number, but obviously I don't know who's texting me. I've fallen down. What do I do? I'm like, what the hell is this? I'll text them, get back up. I mean, you fall, you get up. What do I do? So I'm like, what do I do with this? So I ignore it for a little bit, and then they call the office. Mr. So-and-so fell. Okay, that's a problem. Have him get an x-ray at the urgent care. This is his x-ray. Okay, not ideal, but should heal, right? Would anyone operate on this? Mark? No. So then he comes to the office, it's subsided. Would you operate on it now? No. Okay. His Parkinson's seems to have progressed since I last laid eyes on him. He's just, he's barely standing up. He's shuffling his gait badly. It's terrible. So I'm like, all right, we're going to watch this. And every time I look at it, I get nauseous, but I go, it's going to do pretty good. Not too bad. Oh, look, bridging callus. Perfect. 4 weeks post-op. Let's start some PT. So he's kind of satisfied. 10 days later, okay, 3 months post-op now. Fell again, going to the bathroom. Now he's got this. And now he's like this. So I'll leave you with this. I mean, I'm treating this still a lot operatively because honestly, anything I put in this guy is not going to prevent him from falling. And the worst thing I can do is open him up and expose him to risk of infection, bleeding, nerve injury. So again, I think this drives home the message of when to operate, when not to operate, and when to realize what you're limited by as far as your ability and the patient.